Respected seniors and dear friends, this is Hachal Vadera from Rajkot. As this presentation is recorded for the Anaesthesia Society, I will start with our next conference, that is TechOn 2016 at Ahmedabad. It is to be held on 26th to 28th August of 2016, and I welcome you all for this wonderful academic fest. My today's presentation is on management of anticoagulation in regional anesthesia. Regional anesthesia is nowadays widely practiced because of better patient outcome and better patient satisfaction. Patients are very satisfied when they are pain-free in post-operative period with the help of regional anesthesia. But at the same time, cardiologists are using more and more anticoagulant drugs, antiplatelet drugs and thrombolytic medication because of increased cardiac problems. So what is the real problem? Initially, first study of spinal hematoma showed that incidence of spinal hematoma was 1 into 150 lakhs with epidural, while it is 1 into 2.2 lakh with spinal. But if you see the recent literature, it will show that incidence of hematoma has increased like anything. One of the literature says that it is 1 into 1 lakh for spinal and 33 into 1 lakh, that is 3 into 1000. So that is 1 into 3000 for epidural. So our focus should not only on the prevention of the hematoma, but if at all it occurs, early detection and early treatment is important to prevent any neurological sequelae, because the increased of use of anticoagulants and antiplatelet medication, there are chances of hematoma. So if you detect it early and treat it early, there are less chances of neurological complications. If you look at the literature, you will find many such cases: spinal epidural hematoma after spinal anesthesia in a patient treated with clopidogrel and enoxaparin. This is another case report of extensive retroperitoneal hematoma without neurological deficit. Why neurological deficit doesn't occur with lumbar plexus? Because it is an expandable compartment. If you give lumbar plexus block and if at all hematoma occurs, it is an expandable compartment. So compression of the hematoma over neurological structure is less as compared to epidural. Epidural space is a very less expandable compartment. If even with small hematoma, it will lead to neurological deficit if untreated. So with lumbar plexus, there will be hematoma. The patient will be unstable hemodynamically, but there are less chances of neurological damage if you treat it on time. This is another case report of psoas hematoma with lumbar plexopathy. Here there was lumbar plexopathy after lumbar plexus block because of hematoma. This is hematoma after epidural anesthesia in the presence of antiplatelet and heparin therapy. So you will find many such case reports in the literature. So it is not that uncommon what we think of. That's why American Society of Regional Anesthesia came with some guidelines. In 1998, first consensus conference on neuraxial anesthesia and analgesia was held, and they prepared some guidelines. In 2002, these guidelines were revised, and most recent is in 2010. That is the third edition of the guideline. These guidelines are formalized to assist the anesthesia provider in decision making whether to give regional anesthesia or not in patient with such medications. We encounter patients with antiplatelet medication, with oral anticoagulants, uh, with standard heparin and LMWH. Antiplatelet are used in the patient with stents, oral anticoagulants in the patient with valve replacement or with DVT. Standard heparin or LMWH is commonly used in joint replacement procedure and major hip trauma nowadays. Some of the patients come with some herbal preparation. They might have effect on coagulation, and there are some new anticoagulants. So we will discuss all this medication one by one. Thromboprophylaxis when we need it. There are risk factors of venous thromboembolism. Risk factors are surgery, major trauma, cancer surgeries, bariatric surgery patient with joint replacement, female patient taking oral contraceptive. So these are the patients are at increased risk of thromboembolism. According to the risk, there are categories like low risk, moderate risk, and high risk. Minor surgeries are with least risk and they require early ambulation. Moderate risk is with open gynecologic or urological procedure, and they may or may not require LMWH, but they must require mechanical thromboprophylaxis. And higher risk is associated with THR, TKR, major hip fractures, obese patients, spinal cord surgery, and they require mechanical as well as pharmacological thromboprophylaxis. Perioperative management of patient on antiplatelet therapy. As we all know, patients with bare metal stent and drug-eluting stent come to the surgery many a times. And in this patient, we have to plan the procedure. If surgery is planned surgery, we have to postpone, and if it is emergency procedure, then we have to do it after 4 to 6 weeks of if it is emergency procedure, then we have to continue aspirin and go for surgery. But for planned surgery, we have to postpone for 4 to 6 for bare metal stent, while for 12 months for drug-eluting stents. There are risk factors which are associated with spinal hematoma. There are certain patient factors, there are certain anesthetic factors, and some of the factors are LMWH dosing factors. Female sex, increased age, spinal stenosis, ankylosing spondylosis, renal insufficiency. These are the patient factors which are associated with high risk of spinal hematoma. While there are certain anesthetic factors, like if we do traumatic needle puncture or catheter placement, then there is increased risk of hematoma. Epidural is with more chances of hematoma as compared to spinal. And if we have indwelling catheter, epidural catheter during LMWH administration, then there is increased risk of spinal hematoma. LMWH dosing, if we give immediate preoperative or intraoperative LMWH, then increased risk of spinal hematoma. Early postoperative LMWH administration, concomitant other drug administration, and twice daily dosage is associated with high risk of spinal hematoma. So, what is the specific guideline for various drugs? First, we will discuss about antiplatelet medication. Aspirin, NSAID, thienopyridine derivative, platelet glycoprotein 2B3A inhibitors are the commonly used antiplatelet medications. Aspirin, it blocks cyclooxygenase and it is responsible for the production of thromboxane A2 which inhibits platelet aggregation and causes vasoconstriction. Duration of action of aspirin, it has got irreversible effect on the platelets. So once patient is on aspirin, it will act till the life of the platelet. So platelets lifespan is of up to 7 to 10 days. That's why we advise to stop aspirin for 7 to 10 days whenever we are going for major surgeries which are associated with bleeding, like neurosurgery or TURP. These are the surgery where we should avoid giving aspirin if possible. Long-term use of aspirin may lead to decrease in prothrombin production and result in lengthening of the prothrombin time. So this should be kept in mind. NSAID, again they inhibit cyclooxygenase, and duration of action, it ranges from 1 hour to 3 days, and its effect is reversible. It doesn't affect on the platelet for lifespan. So what are the ASRA recommendations? For aspirin, either medication alone does not increase the risk. So if patient is only on the aspirin, then you need not worry about spinal hematoma. But if patient is taking another antiplatelet or anticoagulant medication, then there is increased risk. Suppose patient is on dual platelet, then there is increased risk. There is no wholly accepted laboratory test by which we can predict whether it will cause spinal hematoma or not. TEG may some guide, but it is not, even it is not 100%. Normal bleeding time does not indicate normal homeostasis, or reverse, like abnormal bleeding time does not necessarily indicate abnormal homeostasis. But if patient give history of bruising easily, history of excessive bleeding, female gender and increased age, then we should be careful when we are giving epidurals in such patients. Thienopyridine derivative, they are used nowadays along with aspirin as an antiplatelet agent. They interfere with platelet membrane function by inhibition of ADP-induced platelet fibrinogen binding. They, they also have irreversible effect on the platelet function for the life of the platelet. But these agents' half-life is prolonged. That's why ticlopidine should be stopped 14 days prior to the neuroaxial block, because even if platelet get replaced with newer platelet, because of ticlopidine action, newer platelet will be affected by ticlopidine. So we have to stop it for 14 days, and for clopidogrel it is 7 to 10 days. There is no accepted laboratory test for this medication also. Platelet glycoprotein 2B3A inhibitor. They are F6 eptifibatide, and tirofiban. These drugs are used for unstable angina and patient immediately after angioplasties. So these drugs are used by cardiologists. They reversibly inhibit platelet aggregation by interfering with platelet fibrinogen and platelet von Willebrand factor binding. Duration varies with various medication. F6 it is 24 to 48 hours, while for eptifibatide and tirofiban it takes 4 to 8 hours until there is normal platelet function. So what are the ASRA recommendations? No neuroaxial blockage should be undertaken until platelet function is normal. As such, immediately after unstable or angina or angioplasty, we rarely require surgery immediately. Glycoprotein 2B3 inhibitor are contraindicated within 4 weeks of the surgery. If patient has undergone surgery and he or she develops unstable angina or EMA in the postoperative period and he requires angioplasty, then this drug should be avoided for 4 weeks. If one has received postoperatively after a neuroaxial block, there should be careful monitoring of the neurological status. If at all it requires, we have to carefully monitor the neurological status of the patient, because there are chances of spinal hematoma and neurological dysfunction. Warfarin, it is most commonly used drugs. It inhibits vitamin K formation, and it affects on the vitamin K dependent factors. It affects on the prothrombin, factors 7, 9 and 10. Its onset start at 8 to 12 hours and peak effects occur at the 36 to 72 hours. So what are the recommendations? For surgery, we have to discontinue warfarin at least for 5 days. If patient is at increased risk of thromboembolism, then we have to bridge it with the subcutaneous LMWH or with intravenous heparin. And we have to give last dose of the preoperative LMWH 24 hours before the surgery, and we should continue immediately after the surgery. And we have, if we require surgery, we have to assess INR 1 day before the surgery. If it is more than 1.5, then we have to give vitamin K orally or intravenous. In case of emergency surgery, we have to give fresh frozen plasma. For regional anesthesia, we have to evaluate patient for the use of concomitant medications. It should be stopped 4 to 5 days prior to the surgery, and we have to check PT and INR before the surgery or before the neuroaxial block. If patient has taken preoperative warfarin before 24 hours the surgery, then PT and INR should be checked, and then only we should proceed for the neuroaxial block. Patient receiving postoperative epidural analgesia and warfarin should have the PT and INR monitored regularly. If patient have epidural catheter in situ, we have to monitor PT and INR regularly, and we have to assess the neurological function daily. Here there is an important point. We should give low concentration of local anesthetic or only opioids for analgesia purpose, so that we can assess motor and sensory function well in the post-operative period, especially patient is taking anticoagulant medication. So we should use low concentration local anesthetic or opioids for this patient. When we need to remove catheter, if INR is more than 3, we should stop the warfarin. Epidural catheter should be removed only when the patient INR is less than 1.5. If removed with INR more than 1.5, then patient should be monitored for the neurological deficit at least for 24 hours, and I will say we should monitor them for 48 hours. Standard heparin. It binds with the antithrombin 3, neutralizing the activated factors of 10, 12, 11, and 9. Its duration of elimination half-life of IV heparin is 56 minutes. So what are the ASRA recommendations? Mini-dose subcutaneous heparin does not contraindicate the neurological blocks. If we are giving 5000 units subcutaneous twice daily, there is no contraindication. Even with higher doses, we require enhanced neurological monitoring. We don't need to avoid epidural or spinal in this patient, but we have to follow certain guidelines. Patient on heparin for more than 4 days should have to assess platelet function, because these patients are at risk of heparin-induced thrombocytopenia. If patient requires heparin, then we should give heparin only after 1 hour of the neuraxial block. Suppose you have given neuraxial block, epidural or spinal, and patient require heparin intraoperatively, then it should not be given at least for 1 hour after the procedure. If patient have indwelling catheter, it should be removed only after 2 to 4 hours after the last dose of heparin, and we should evaluate PTT before that. Heparin should not be reinitiated until 1 hour has passed after removal of the epidural catheter. So, 3 important points: we should not give heparin for 1 hour after epidural catheter insertion. Second is, if you want to remove the epidural catheter, it should be removed 2 to 4 hours of the last dose of heparin. And third point is, we should not repeat the heparin up till 1 hour after removing the epidural catheter. If a bloody tap has occurred, it should be communicated with the surgeon, and no data suggests that it is mandatory to cancel the surgery because of that. LMWH. These drugs are widely used nowadays to prevent DVT. They are given for DVT prophylaxis. Various agents are available in market, and they are practiced widely for joint replacement, for major hip trauma, for prolonged surgery, for bariatric surgery, for laparoscopy surgery, and many other surgeries. There are certain factors for hematoma formation with enoxaparin. They are female gender, elderly, traumatic needle or catheter placement, and indwelling catheter present during LMWH administration. LMWH administration and risk of hematoma formation. Continue epidural administration and LMWH increases the hematoma formation up to 1 into 3000. And even with spinal, one of the studies says that it is 1 into 40,000. So we have to be careful when we are using LMWH along with regional anesthesia. LMWH mechanism of action: it affects factor 10. LMWH does not alter the patient's PTT, and there are no laboratory tests to measure its actions. So what are the ASRA recommendations? Assess the patient for concomitant medication as any other drug. If at all bloody tap occurs, we have to communicate with the surgeon, but don't cancel the surgery. If we want to give LMWH after bloody tap, then we should hold it for 24 hours. Start LMWH only after 24 hours after bloody tap. LMWH should be held for 10 to 12 hours prior to neuraxial block for normal dosing. So we have to stop it before 12 hours when we want to give epidural or spinal. But if patient is taking in the higher dosages, then we have to hold it for 24 hours. Twice daily dosing, we have to hold it for 24 hours. If patient have indwelling catheters, it should be removed prior to the initiation of the LMWH in the post-operative period. If we require continuous technique, uh, then the catheter should be removed the next day with the first dose of the LMWH occurring at a minimum of 2 hours after the catheter removal. So, dose of the LMWH should be given only after the only after 2 hours of the catheter removal. Thrombolytic and fibrinolytic medications. Original recommendation was to withhold neuraxial blockage for 10 days, but there is no enough data. If a patient has received neuraxial block and the unexpectedly received thrombolytic medication, then we have to monitor the patient for neurological complication, and there is no contraindication related to the removal of epidural catheter in the patient who unrepentantly received thrombolytic therapy. So there are no specific recommendation. For herbal preparation, garlic, ginger, feverfew, ginseng, these drugs have got antiplatelet properties. There are many other herbal preparation which affects on the coagulation profile. So if patient is taking herbal preparation, we have to check. There is unknown risk, and most patients are advised to stop for 5 to 7 days prior to the surgery. And we have to screen for concomitant use of other medications. Assess the patient for bleeding tendency, but there is no specific recommendation for this preparation. Newer anticoagulants. Nowadays, in market, we find many newer anticoagulant drugs. Fondaparinux is one of it. It is used for DVT prophylaxis. It binds with angiotensin 3, which neutralizes the factor 10A. Its peak effects starts in the 3 hours with half-life of 17 to 21 hours. It has got irreversible effect and need further clinical expertise to formulate guidelines. So there is no specific guideline for fondaparinux to give regional anesthesia or not. So we have to be careful if we are using regional anesthesia in this patient, and it should not be given at least for 24 hours as half-life is 17 to 21 hours. Bivalirudin, lepirudin, these are the other drugs which are used nowadays. Caution is advised, but no specific recommendation because of limited clinical experience. Dabigatran, Itaxilat, and rivaroxaban. Rivaroxaban is used nowadays commonly, but these drugs are under trial. Rivaroxaban has elimination half-life of 9 hours and 13 hours in elderly with altered renal function. So if patient is on this medication, we have to be careful. There is no specific guidelines, but we can give spinal or epidural at least after 2 to 3 days, and we have to be careful in monitoring in the post-operative period. Now, epidural hematoma, how to diagnose and treat. It is a real scary condition. If it at all occurs, it is a nightmare for an anesthetist. Signs and symptoms: patient will complain of low back pain that is sharp and irradiating. Patient will have sensory and motor loss. Patient will complain of numbness and tingling, motor weakness long after block should have abated. That's why this patient should be given low concentration of local anesthetic or opioids so that we can detect these signs early. Patient may develop bowel and bladder dysfunction and sometimes perioperative. MRI is the diagnostic test for this hematoma, but if it is not available, then we can go for CT scan or myelogram. Treatment and outcome: it must be treated within 8 to 12 hours of the onset of the symptom. Even if it is treated within 8 hours, there are reports of permanent neurological deficit. So emergency decompression laminectomy with hematoma evacuation is the only answer, and outcome is generally poor if treated late. Factors affecting recovery: size and location of the hematoma, speed of hematoma development, and severity and nature of pre-existing neurological problem. These are the factors which may affect the recovery. So this is about neuraxial blocks and anticoagulants. Now we will talk on anticoagulation and peripheral nerve blocks. There are case reports of major bleeding after psoas compartment block and lumbar sympathetic blocks. If we accidentally puncture vessels during this block, there will be formation of big hematoma, and that will patient will deteriorate rapidly hemodynamically. Patient will develop hypotension and hypovolemia and tachycardia and shock. Patient with neurological deficit had complete recovery in 6 to 12 months. Why this? Because this is because this space is expandable, and the key to this reversal was the fact that bleeding occurred in the expandable tissue as opposed to the non-expandable compartment associated with neuraxial block. So this compartment is expandable, so there is less chances of neurological deficit as compared to epidural. There are some reports of complication with axillary, infraclavicular, supraclavicular, interscalary block in literature, but they are very few. This complication occurs because of accidental puncture of the vessels surrounding this neurological structure. If these vessels get punctured, there are chances of hematoma formation, and sometimes this hematoma will compress the neurological tissue and lead to neurological damage. But risk is lower with ultrasound guided blocks, especially in the train ends. Why I'm telling us in the train end? Because if you are not trained enough, then there are chances of vessel puncture even with ultrasound. If you don't visualize the needle tip with ultrasound and inject the drug, try to inject the drug, there are all chances of vessel puncture, and there are chances of local anesthetic toxicity as well. If we look at the relative risk of neuraxial and peripheral nerve blocks in patients with abnormality of coagulation, there is least risk with local infiltration followed by superficial blocks, facial blocks, superficial perivascular blocks, deep blocks, paravertebral blocks, spinal, single shot or epidural, and maximum risk is associated with epidural with catheter. There are certain medical and surgical conditions which are associated with coagulation abnormalities, and we should think of giving. We should think before giving epidural and spinal in such cases. They are trauma, sepsis, uremia, liver failure, massive transfusion, and DIC. These are the patients where we should avoid a spinal and epidural as if it is possible. So take home message is, we have to check for the concurrent use of coagulation altering medication that may increase the risk of bleeding without altering coagulation study. So even if coagulation studies are normal, there are chances of bleeding and neurological complication if patient is taking more than one medication. When providing postoperative analgesia with an epidural, use opioids or dilute local anesthetic with low concentration to allow for neurological evaluation. So this is very important. We have to use very low concentration LA or opioids so that we can evaluate the patient neurologically in the postoperative period. We have to remove catheter at the nadir of the anticoagulation activity and do not give additional anticoagulation immediately after the removal. Follow the guidelines. Suppose patient is taking a LMWH, we should not give it for 2 hours after removal of the catheter. Suppose patient is taking heparin, intravenous heparin, we should hold it for 1 hour after removing the catheter. Frequent evaluation of the neurological status of the patient should be pursued for the early detection of the epidural hematoma. So this is very important. We have to do frequent neurological evaluation in this patient. So a regular follow-up of the patient is mandatory if we use epidural in patient with anticoagulants. In high risk cases, continue monitoring neurological status for 24 hours post-catheter removal. So this is all important point when we are using regional anesthesia, especially epidural or spinal in patient with anticoagulants. So this is all about regional anesthesia and anticoagulants. Thank you all. What do you know?